stage, as I mentioned in the other slide, those frequently are the ones that are not diagnosed. There's also historically a longer time to follow up on abnormal results. Unfortunately, if there's not a well-established primary care doctor or a well-established network of healthcare providers for our minority women, there's a longer time to follow up on abnormal results. So that means there's a lag time in diagnosis, a lag time in further evaluation if needed, as well as a lag time in getting to a specialist that can guide standard of care, optimal intervention, and treatment planning. Disproportionate use with hormonal therapies has everything to do with once African American women are diagnosed with early stage breast cancer, much of that breast cancer is what we call hormone sensitive or estrogen and progesterone receptor positive. The treatment modality that anchors survivorship within those women that have hormone positive breast cancer is oral endocrine therapy. However, an accurate explanation of the importance of that therapy, as well as helping women adjust and find which therapy is best for them, is frequently not followed through on. Next slide, please. What are some standard recommendations? Everyone is very interested in understanding, what should I do? There's a lot of mixed information and mixed messaging. I'd like to try to clarify that for us today. Women at average risk nationally are ages 40 to 44, specifically with no personal history of breast cancer in the past. They have no known or suspected genetic predisposition. As Lindsay mentioned, most commonly we think of the BRCA1 or 2 gene. They don't have a strong family history, specifically a first-degree relative. I frequently get asked, what is a strong family history? We're talking about a mother, sister, or child, first-degree relative with breast or ovarian cancer. And frequently not understood is a history of previous radiation therapy to the chest. This is associated with a second malignancy or an early childhood cancer like lymphoma or something that requires radiation therapy. So for those women considered average risk, age 40 to 44, they should have the opportunity to begin annual screening. Ages 45 to 54, they should undergo annual screening. Ages 55 and older, they can transition to screening once every 1 or 2 years, as long as they continue to screen through a life expectancy of 10 years or more. I'd like to pause here and say that nobody knows what another person's life expectancy is. Unfortunately, I see too many African American women in their 80s that were told by their doctor, well, you don't need to get mammograms anymore. It's very important, community, to know that the average life expectancy for all women in the United States is 78. That means half the community will live longer than that. So be very careful about declining imaging, and please encourage your family members, your mother, and yourself to ask about screening. Next slide, please. Next slide, please. Women at high risk. Women that are at high risk are women that have a lifetime increased risk of breast cancer that's greater than 25%. This can be assessed via risk assessment tools, as well as genetic counseling, which is so very important, especially if you have a family history of what? A first-degree relative with breast or ovarian cancer. If you have a genetic variation, BRCA1 or BRCA2, then you're considered high risk, and as I mentioned, a strong history of breast or ovarian cancer or prior chest radiation. Why do I say that? You should begin annual screening earlier, age 30, and definitely discussion, if not ordering of an MRI. Next slide. It's also important to say that updated recommendation to begin screening at age 40 is very consistent across well-respected Universal Preventative Task Force, the NCCN, National Cancer Network, and the American College of Radiology. Breast cancer death rates continued to decline in African American women by 1.4% per year, according to this task force and the NCCN, supporting that early detection through the use of screening modalities is critical. Next slide, please. What do we know about breast cancer risk? Being born female at birth, as well as aging, which is something we all hope to do, are primary universal risk factors across all communities. Family history of first-degree relatives as doubles our risk. 5 to 10% of breast cancers are linked to genetic mutations, and that is very uncommon, which means 90% are not genetically inherited, though there can be family cancer syndromes. What does this mean? BRCA1 carriers, as well as BRCA2 carriers, have a higher risk of getting breast cancer in their lifetime. That's a 70% chance by age 70. Next slide. What do we know about breast cancer risk? Continuing, if you've ever had a needle biopsy and it's come back abnormal, even if you didn't require surgery, even if you weren't sent to a surgeon or a specialist, please understand this increases your risk, and this means annual screening as well as clinical exams are critical. Age less than 12 with your first menses and a later onset of menopause are considered soft risk factors for increased risk. High breast density has gained a lot of popularity in the community from an educational standpoint. It's important to know that this really increases the challenges with diagnosis because frequently breast density eludes or makes it hard to find small breast cancers with standard mammography because high density means more glandular breast tissue, which is white on imaging. Next slide. What is the risk of developing breast cancer over the years? I appreciate the spectrum of callers that I'm honored to present to today. Here's the data from SEER. SEER is a national, well-respected database that really is about 2 years old, but this is a projection. Over the next 10 years, women age 30 have about a 0.5 or a 0.5% risk of getting breast cancer. That's 1 in 204. Age 40, about a 1.5% chance over 10 years of getting breast cancer. Age 50, 2.4%. Age 60, 3.5%. Age 70, 4%. So merely aging is a risk factor. These numbers are for all women, not just African American women. Next slide, please. What can we do to reduce risk? I get this question frequently. Weight control, specifically diet and exercise. For my sisters in the community, this is not about a number on the scale. While that is important and you should work with your doctor to have a healthy weight, we're talking about diet and exercise. Why do I say that? We know through many randomized clinical studies that visceral fat creates an inflammatory environment that's full of tumor growth factors. Think of fertilizer. Visceral fat means within the abdomen and stomach inside. How does that translate? Obesity suppresses or lowers our immunity. And that means our immunity to abnormal cell turnover, abnormal cell growth, abnormal cell aging, which is what we believe occurs with breast cancer. Next, alcohol use. 2 or more drinks per day confers a 20% higher risk of breast cancer across the board. So while you can enjoy your libations, please be very careful with your alcohol use, especially as you age, because as you age, your breast cancer risk increases. Breastfeeding offers a small protective benefit, and menopausal hormone therapy use. This has been a very hot, misunderstood topic, otherwise known as hormone replacement therapy. Menopausal hormonal use is frequently given to abate or lessen menopausal symptoms. Estrogen and progesterone are frequently prescribed for women that womb in place. It is well known that use greater than 5 years increases risk. So I'm not saying don't use it. I'm saying work with your doctor, keep track of how long it has been used, and understand what your risk is so that you know where you are. Of note, use of estrogen alone, which is only safe in women without a uterus, has a lower risk. Next slide, please. What's on the horizon? What's new? What I'd like to do is impart the importance of research. Frequently, as a community, research opportunities have not been at our disposal. Ask. Genetics and breast cancer in Black women is being studied. A group out of Vanderbilt is looking for gene variants specific to African American women. And these variants, we're not talking about BRCA1 and BRCA2, help us understand more about triple negative breast cancer and the increased incidence or likelihood of African American women of younger age having triple negative breast cancer. What's next? Weight loss medications are very, very hot topics now. We're talking Zepbound, Mounjaro, Wegovy. I want to call the names that you may be familiar with. There are clinical trials, specifically one that is being opened by Texas Oncology, that is examining the use of these GLP-1 shot medications, specifically Mounjaro, in reducing weight and directly correlating that with a decrease in risk of breast cancer recurrence. So yes, you have to unfortunately have suffered breast cancer, but this is being studied. This is in an effort to not preach to women about weight loss, to not victimize them for struggles with obesity, but for us as oncology specialists to partner with you to optimize and lower your risk and improve your survival. Circulating tumor DNA is also being looked at very carefully. If weight loss leads to lower circulating tumor cells in the blood, then it will help us tailor bariatric surgery or weight loss surgery, and the use of GLP-1 medications, Wegovy, Zepbound, Mounjaro, within our treatment plans to help lower the risk of recurrence. Last but not least, epigenetics is a very, very confusing term. Essentially, women, what I'm trying to relay is epigenetics implies that some risk factors are already embedded historically. Social determinants of health, pollution. These types of things are imprinted within our DNA without changing its structure. So some things we cannot control, but if we understand them, we can do a better job of addressing them. Next slide. Thank you so much, team.
Thank you so much, Dr. Terry. I wish that we could give you all an applause, but thank you so much for that highly informative presentation and for comprehensively educating us about the latest research on early detection and risk reduction to really help women understand how to take charge and advocate for their best breast health and outcomes. So thank you again. Dr. Terry will now be joined by our panelists, and I'm elated to introduce you to another member of my breast care team, Dr. J. Lindsay Silas. She is a board-certified OB-GYN dedicated to empowering women through safe, informed care. She practices at Bella Obstetrics and Gynecology and she brings award-winning expertise from Case Western and Washington universities. She is a passionate and committed to closing disparity in their families. So let's welcome Dr. Silas to the pink room. And she will be joined by my breastie, Tamika Bryant. She is a 12-year breast cancer survivor who turned her stage 2B triple negative diagnosis into a mission for change. She's an advocate for Susan G. Komen and the American Cancer Society. Tamika shapes healthcare policy and supports research. She empowers entrepreneurs through Shades of Social Media, her platform, and she shares her passion for wellness, travel, and body positivity on Life in Pumps. Tamika is a dynamic media personality who's been featured on Forbes, QVC, and Fox 29 in Philly. So welcome to the panel, Tamika. Okay, ladies, let's get started. First, I want to talk about advances